Hello, everyone, and welcome to day 2 of our NAPAC Symposium 2020, which is, of course, a virtual event. We thank you all for your attendance and participation yesterday and look forward to yet another day of exciting talks in our 4 sessions. I want to start things today with our session on transplantation for bone marrow failure. I have the pleasure of kicking off day 2 of our symposium with this session. We have a group of diverse experiences and background for you today. First, Dr. Regis Peeinfault de Latour is a full professor of hematology and bone marrow transplant at Hospital Saint Louis and has a doctorate in immunology. He also serves as secretary of the Severe Aplastic Anemia Work Party for the European Blood and Marrow Transplant Society. He is joining us all the way from Paris to share the European experience with transplant for sibling-related and unrelated donors, as well as alternative donors. Dr. de Latour?
Before you start really quick, my friend, if I could just encourage everyone to use the Q&A chat box to put their questions in throughout. It worked really well yesterday. Please feel free to ask questions as the conference goes on. Thank you so much.
Okay, so good afternoon, everybody. Good evening. I'm very pleased to belong to this program and I'm very pleased to share with you those thoughts about transplantation in idiopathic aplastic anemia. I will be discussing these talks at the end and we'll stay together for the 2 hours. So if there is any questions, I will also participate to the debate from the entire session. So first of all, the next slide is summarizing my disclosures. So please, next slide. Okay. So basically what I would do in the next 20 minutes or so is to use the aplastic algorithm to go through this transplantation place. So basically, this is the next slide. The HLA identical sibling donor is still a matter of choice for patients that are older of 40. So obviously for pediatric, that I think is mainly in the audience. This is the main choice when you have a sibling available. You should use marrow to avoid the risk of graft-versus-host disease. Cyclophosphamide and ATG is still conditioning regimen that is recommended. And we have a prospective trial coming from Italian colleagues showing that the association of cyclosporine plus methotrexate is doing better than cyclosporine alone. So this is a standard of care. And the next slide is just summarizing the results long-term that we got in Saint Louis Hospital in about 61 patients who received this regimen being transplanted because of aplastic anemia using a sibling donor. And I would say that this is just reproducing what we observe worldwide using this regimen. I think this is still the best. For transplant patients are doing great, about 90% overall survival long-term. You can see here the median follow-up was about 80 months, so the data are considered robust. And on the right side, you can see that the complications are very few and not higher than what we're observing with controls, not transplanted patients. The only complications we're observing a bit higher than what we can observe normally is osteonecrosis. This is something that is not related only to transplant because we also have some kind of complication in immunosuppression, but about 25% of patients are still exposing to this risk. But again, this is the best treatment. Next slide, the limitation, however, is still the age. So for you, I think it's not a problem because we are speaking to pediatricians. But for adults, as you can see here, on behalf of the BMT or CIBMTR, age is still matters. And we are still facing this 40 years age limit even in 2020. So of course, we're trying to use new conditioning regimen, FCC, for example, campus-related regimen, but age is still a problem related with bad or worse overall survival long-term. So the next slide, please. Down, if we go to patients who don't have any related donors, the standard of care is ORS ATG plus cyclosporine. But, and this is the next slide, we are at the moment questioning the place of much unrelated donor transplantation in this situation. Next slide, please. So basically, the idea was coming from UK, who were using a campus-wide regimen that was published some years ago by Sujit Samarasinj. And what he was observing is excellent survival in refractory patients to immunosuppression. You can see here 44 patients, median age 11 years, so really pediatric populations, and outstanding results with 95, not only overall survival, but failure-free survival. So this is the reason why, and this is the next slide, at the time that they were not possibly accessible to horse ATG, it was only rabbit ATG in UK at that time, they decided to go first line because the treatment was doing outstandingly well for second line, so they were going first line. It was this publication. It was a retrospective study, few patients, 29, however. But as you can see, using match unrelated donor upfront in pediatric patients was giving outstanding results with only one graft error, very few rates of GVHD, and only one death. So, of course, we came to the next point. This is the next slide. And I think you can go twice because there is the pros and cons. This attitude in patients. First of all, of course, in pediatric patients, the toxicity is lower. Your patients are supporting better transplant, so we want to cure them, and this is a real curative options. However, there is cons. The most important ones is the fact that some of the patients have probably not been transplanted in that study, and we don't know how many. So in other words, we don't have prospective randomized trials that are robustly showing that we should use match unrelated donor upfront. We are showing patients who have been successfully transplanted. And what we want to know is the patients who are indicated for match unrelated donor transplantation upfront, but did not succeed because the donor canceled last minute, and we are all experiencing this, and not only in the COVID situation we are living now, because for any reason, the recipients is not eligible anymore to transplant because he can do from fungal infections and so on. So that's the reason why that until now, and this is the next slide, we are still recommending for standard of care to give immunosuppression to those pediatric patients and then to go to transplant early on, 3 months after treatment if they're refractory, but at least not let patients outside treatment. However, as you can see the next slide, and you can go twice, please. So this is the results we got, and that is going to be presented at ASH this year, retrospectively on a higher number of patients. The median age of this series is about 20 years of age, so mainly young patients. And then you can see here using upfront match unrelated donor in Europe. This is an EBMT study. Is giving quite good results. I mean, it was about 86% overall survival and 81% GRFS. The median follow-up of that study is 2 years, and it's about 65 patients. So this looks like as a good option, but it needs to be proven. So we have some randomized prospective trials going on, one in the US. We are initiating in France. I would say that, yes, that's possibly something very interesting. Again, that needs to be prospectively confirmed, but this is really something moving. So the next slide, please. So coming to the algorithm, I cannot not say a word of immunosuppression. This is the next slide. As you can see, there is a kind of revolution in the field of aplastic anemias. NIH shows in 2017 in the phase 2 trial that the addition of eltrombopag to horse ATG plus cyclosporine was giving rise outstanding results. It was about 90% overall response rates, while normally using immunosuppression, we are rating about 60% response, so 30% more response in those patients. Of course, this is a transplant talks, but as you know, if you want to be a good transplanter, you have to know what's going on the other side. And basically, what we did with Antonio and the entire working party of EBMT is to run the phase 3 trial in Europe. It was about 6 countries. It was 200 patients and so on. The next slide is summarizing the design of that study. It was a one-to-one randomization. Patients were receiving older than 15 years of age in case of severe, very severe plastic anemia, or the standard of care for 101 patients. Top slides. or 96 patients received at the top of filter thrombopag. And basically, the biology was centralized at King's, and the inclusion criteria was stratified according to disease severity and age. The study reached the primary endpoint, and we showed in that study there was a significant increase in terms of response rate. I'm not going to spend more time because it has been published and presented, not published, but presented at EBMT, so you could log on and see the presentation, the entire presentation. This is outstandingly exciting because we are improving response rates, so obviously it's going to play a role even for transplanters in the algorithm of aplastic anemia. The safety short-term was okay. And of course, we have the RAISE-2 trial that is going on for the long-term follow-up of those patients to know that if 10, 15 years of now, the use of a thrombopag added to the standard of care will higher the risk of clonal evolution. This is something that for the moment, nobody can say anything because there is no well-run studies. There's just retrospective attempts to answer to that questions, but we will know long-term. So the next slide, it was just here to summarize the new things coming in the field. So next slide, please. Yeah. So now, if you don't have a sibling, you go to ORS-ATG plus L-Thrombopag. I told you this place of, no, please come back. I told you the place of possibly match-unrelated donor upfront. So now the question is, when you have refractory patients, who should receive a match-unrelated donor transplantation after immunosuppression? So basically, we are all using in this situation that is quite common, unrelated match-unrelated donor. We are all using marrow again to avoid the risk of graft-versus-host disease as quick as possible in the history of the disease. We know that this is the main prognostic factor for patients, and we are all using the same kind of regimen, except possibly in UK because they have access to campus, but it's more or less a regimen using this. And as you can see here, what is really playing a role is his age. And again, we have 40 years of age using siblings, and here it's 30 years of age. So again, you're not really concerned because as pediatricians, obviously, your patients are younger. But for us, this is something that didn't change since many years. And again, challenging in adults because it's not the case for other indications. So next slide, please. So this is basically a, I would say, algorithm that helps to indicate for refractory patients the use of match-unrelated donor transplantation in aplastic anemia. What we did use in France, it was 3 factors, being 30 years of age or less, that's all your patients, having a match-unrelated donor available compared with a mismatch-unrelated donor, or being transplanted something else than in the first year after diagnosis. Those are the main 3 factors that has been recognized to have been associated with good prognosis transplanted patients with aplastic anemia using match-unrelated donor. And as you can see on the left side of the slides, it was playing a high role because patients who have 1 or 0 risk factors were playing a very good overall survival, and that was validated in a validation core coming from the working part of the severe aplastic anemia working part of the EBMT on almost 800 patients. So this is the reason why at the moment, and this is the next slide, if a patient is refractory to immunosuppression and if he's young, so for all pediatricians, of course, patients, and more if in the first year after diagnosis, or if he has a match-unrelated donor, then he has to go to transplant. There is no discussion. This is standard of care. This is the next slide. So now the end of my talk, this is the next slide, will address this very difficult situation of patients that we do know are refractory to immunosuppression. Obviously, if they have not been transplanted before, this is because they didn't have any sibling donor and neither some match-unrelated donor. So the question is, which patients should receive a thrombopag? Which patients should go to alternative transplantation? So just some flavor to be able to decide. So this is the next slide. I think that the most important study, next slide, please. The most important study is that we should all have in heads as transplanters addressing these questions is clearly what not transplant is doing. And this is a very old study, but is, for me, the most important one when we are thinking about alternative donor in aplastic anemia. It was coming from NIH, or they plotted according to overall survival and according to the period of treatment patients who were refractory to immunosuppression. And as you can see here, we did tremendous progress in the supportive care of aplastic anemia patients. You can see that group 1 was treated before 96, group 2 who was treated between 96 and 2002, and group 3 who was treated between 2002 and 2008 was doing better. And we were at the same time keeping 10-15% more in terms of overall survival just using supportive care, transfusion, and antibiotics. And this is the next slide, before L-Thrombopag was available. So again, that's the reason why when we are addressing alternative transplantation using cord blood, mismatched donors, or haplotransplantation, we should really think twice for our patients to be sure that we are not going to make them facing a possibly higher toxic treatment than just supportive care. So I agree that for patients that are pediatrics, this is more something that might be indicated, but for our adult patients, this is something really questionable. So the next slide, please. So something that, perfect. So something that we all agree on is that I told you 40 years of age for siblings, 30 years of age for match unrelated donor. And for alternative donors, I would say less than 20 years of age. So we are not indicated classically alternative donors without discussion, tremendous discussions with patients and physicians, colleagues, and so on. If the patient is older than 20 years, it's really the cutoff that the toxicity looks really greater and unacceptable using this kind of transplant in those patients. So we are using it, of course, only in refractory patients. There's two things that we have to verify before going to alternative transplantation in our aplastic patients. First of all, if we did not miss a constitutional disorder, because this is something that may happen. The constitutional disorders, and I think there is some presentation afterwards, like this keratosis congenita or Fanconi anemia, they are not responding to immunosuppression. So please, when a patient is refractory to immunosuppression, first check your diagnosis. First check that you are not doing a mistake. It's not always obvious. Fanconi or this keratosis patients are not always evident, and it's really important to think twice to the diagnosis because the patient is refractory to immunosuppression. And the second thing that we have to check that is really important 6 months after the beginning of the immunosuppression is the clonal evolution, doing a marrow sampling to see if your patient is not presenting a monosomy 7 or something that might explain that is refractory to immunosuppression and definitely need transplantation. The other thing that is important in this situation is clearly the use of a TBI2 gray. I know that pediatricians are not willing to do this kind of approach. I may discuss for sure, nothing is in a model, but it's true that those patients, plastics, refractory to immunosuppression are exposed to a higher risk of rejection. And as you know, those patients are really facing long time in aplastic anemia, and they're exposed to high risk of fungal infection. So I would say that it's even more difficult to do 2 transplants, one and then rejection and another one because of this complications. This is the reason why at least in France, we are really using the lower grade, 2 grays, but in this situation, in all conditioning regimen, in all alternative donors, we are using this. So the next slide. It's just to highlight the results we got with cord. I know that cord is not I would say, in the wind again. It's a bit old-fashioned, but I think that we have to take the data that was generated. This is a study we did in France. This is a prospective trial, a phase 2 trial that included 26 patients. The median age of this population was 16 years of age, so really pediatric population. And as you can see, 3 years median follow-up. And basically, the results were outstanding. All patients with refractory, at least 1 immunosuppression using ORS-ATG plus cyclosporine, and we got about higher than 82% overall survival, which was good with good engraftment and so on. And so the receipt was to use, of course, the RIC regimen, TBI2 gray included, There was only 2 days of ATG, 5 milligram per kilo total dose, because if not, you're highering the risk of infections. We also use high number of cells, at least 10 to the 5th nucleated cells before defrozen. And we were also using anti-CD20 at day +5 to avoid the risk of PTLD post-transplant lymphoproliferative disorders after transplant. So this has been published, and honestly, when we got it, refractory patients, pediatric patients, we are mostly using this because really the results were okay, and if you got the good things to do it, it's working quite well. So the next slide, obviously, is what's going on in the world at the moment, is the Pe冶-Ault transplant. So these are the results that has been published last year by Peด๊o on behalf of the Severe Aplastic Anemia Working Party of the BMT. It was almost 40 patients who received a Pe冶-Ault transplant because of refractory aplastic anemia. It was about 32 patients, or because of inherited disorders, it was 4 patients. As you can see, there was a bunch of mortality in constitutional disorders, but again, this is very few patients, and we are at the moment retrospectively assessing all patients in Europe who has been transplanted with Pe冶-Ault in the context of inherited bone marrow failure disorders. We should have more patients and probably rise more in, I would say, instructive conclusions. I don't know what it's going to be, but at least there will be more than 4 patients. On the other side, we got 32 patients who were suffering from idiopathic aplastic anemia, and as you can see, the results were I would say good. Again, retrospective, of course, heterogeneity, of course, there is no monitoring in it, just registry data. But this is important to quote that the results were good, and we are at the moment opening a prospective trial to assess this on a robust basis. In France, there is many trials open worldwide. Baltimore did a lot of work on it, and I guess that we will have a bunch of prospective clinical trials in the coming years that will be interesting to treat patients in this situation. So the next slide, it's a kind of summary of what I told you. So my task today was to address the place of bone marrow transplantation in idiopathic aplastic anemia in 25 minutes. So basically, as you can see, match-related donors are still doing better. Of course, using marrow to avoid the risk of chronic GVHD as soon as possible. This is outstandingly important. I think that we are still delaying too much transplantation for patients. This is not the cancer, this is not the leukemia, so we are transfusing them and waiting to have a space in the unit to do the transplantation. This is not good. We know that after 3 months from the diagnosis, the patients is twice higher rates of complications. So we should, it's an emergent transplant. This is really outstanding results. We should take the time to put those patients who have siblings and have a severe aplastic anemia as quick as possible transplanted. Then for patients who are, I would say, refractory to immunosuppression and are younger and with a match-unrelated donor available, of course, first of all, verifying your diagnosis to avoid that you are still considering the patient as idiopathic and it can be a constitutional disorders. And of course, verifying the absence of clonal evolution, and then go to transplant if you have a match-unrelated donor. Alternative transplantation for us, this is really something deserving age of 20 years or less, so pediatric patients, obviously. We are using TBI to avoid rejection in any of the source of stem cell use, cord blood or mismatched donors or whatever. And regarding Pe冶-Ault transplant, yes, there is a lot of enthusiasm, and it seems it's working well. And again, we have, even if it's a rare disease, to prove this prospectively in controlled trials. So that's what we are doing at the moment, and it's that effort that are doing worldwide. For the match-unrelated donor first line, I'm still claiming it's experimental. I know that it's not all experts that are on my side, but there are so many that are still. I think that we have to be very careful using this strategy because we don't have yet the real good study, meaning patients who have a match-unrelated donor, who have an indication for transplant, but were not transplanted. So that's the way we decided to answer to it in France. We are beginning the first patients in January 2021. So basically, the idea is to register patients who have an indication for transplant and a match-unrelated donor available, and to see how many patients will be transplanted in the 2 months coming. And I think this is a way to address it. But anyway, there is another study coming from North America that is also very good, and we will have some data to see if yes or no we can do this kind of approach or not. So with this, and this is the next slide, this is the most important slide, this is acknowledgement slide. Again, I mean, I'm just the speaker of a group in Paris. I'm very lucky to belong to this group. We have a pediatric site in Robert Debré with Jean-Hugues Dalle, Thierry Leblanc, André Baruchel. We have an adult site in Saint-Louis Hospital with Flore Sick and Gérard Saucier that everybody knows. We have fantastic labs that are interesting in routine care as well as in research, working on Fanconi anemia like Jean Soulier, or telomeres like you can see, Caroline Cangisser, Elodie Lenné, and Lydie Dacosta. And of course, we have the international groups and all my friends on the severe aplastic anemia working party that is working so well. And we are really trying to find the best treatment for patients. It's really coming from few patients in the center and then large study, retrospective study on the European scale or the CIBMT scale. I mean, we are doing the same way. And then we need to verify our data through prospective clinical trials. With this, I thank you very much. I'm sorry to spend time on acknowledgements, but for me, this is the most important because this is the way that allow me to present to you all those data. And of course, I would be more than happy to discuss all what we can discuss and share on the care of those patients in all our centers. Thank you very much.
Thank you, Regis, for a wonderful talk. And I just, again, want to encourage everyone to include any comments or questions that you have in the Q&A box. And we actually do have one from Bonnie, who first says, great to see the data on the various transplant options. Why do you think outcomes are better if patients are transplanted within 1 year from aplastic anemia diagnosis versus later? And I believe this is specifically related to the matched unrelated donor transplant.
Yeah, so we had some unpublished data, but I mean, this is not, I mean, this is something that is reproduced everywhere. There is two risks of delaying transplant. The first one is immunization. So this is for match unrelated donor, especially, not for related donors, but for match unrelated donors, we are favoring immunization with transfusions. The second one is infection, and especially mucormycosis or fungal infections. And we got some patients who were transplanted lately, and typically they were presented as kind of complications. So this is really the reason why we want to do the transplant as soon as possible, that the patients has the shortest time of neutropenia in his history, and obviously the lower rates of transfusion before going to transplant.
Just to piggyback on that question, since you have a pretty mature experience in terms of matched unrelated donor transplants for aplastic anemia, do you have any long-term or late effects data in terms of either transplant-related mortality, fertility, or other late effects of this transplant strategy?
So this is an excellent question. For the moment, there is no real high numbers data coming from Europe on the long term of those kind of patients. There was, of course, a publication, New England 91, from Gérard Saucier, but that's not an update of it. This is very important. This is a study that is going on at the moment, and it's André Bacigalupo proposed it, the Severe Plastic Working Party, is to see, especially at the time of the 2-grade TBI that everybody is criticizing, that if yes or no, this is playing a role, and especially in fertility. So this is something going on behalf of the Working Party. We are using this Bacigalupo regimen, this is the way we are calling it, fludarabine 120 milligram per meter square, Cytoxan 120 milligram per kilo, ATG 7.5, and TIMO and TBI 2 grade since 2010. So we should have some data coming in on the long term of those patients. This is something that we are addressing at the moment.
So that actually, I think, answers another question we had in the box was what conditioning regimen do you propose for upfront unrelated transplant? So I believe you said the Flu-Cy TBI with ATG regimen.
So I would say that there was some discussion on this. I really, the first we did, because of course we did, the first we did, we used Campus. Because the publication I showed to you, the Pewiąault paper, British Journal paper with Stugit Samarin-Singe that is signing last, is Campus-based. So we were using Campus. And when it came for the protocol we are initiating in France, obviously we could not use as everywhere in the world a drug that is not approved anymore. And as you know, Campus is not approved in the transplantation regimen in France. So that's the reason why we came back to this Pewiąault regimen. And I think it's important because at least we can do everywhere in the world. So the trial, and we have few patients, of course, who did it. And in the European study I showed to you, retrospective data, 65 patients, there was some Pewiąault regimen. So it shows that it's working. And that will be the regimen that we are using in the prospective trials. So, yeah.
Another question from the Q&A. Given these data and your comments, are adults aged 20 to 40 years now being evaluated with comprehensive germline testing for inherited bone marrow failure syndromes prior to any type of transplant?
Yeah, so this is a very good question. At the moment, we are doing it almost systematically for pediatric patients. Below 18 years of age, we are going very quickly to NGS panel, and we have also, at the moment, a huge effort on the genomic panel with exomes and stuff. It's a French state initiation, so we are really doing this systematically for young patients. And Jean Soulier is really running a panel that we have the results quickly. And if we don't have the panel results, it's negative, but we have really high arguments to think this is inherited. So familial other patients, something else than hematology, heart problems, kidney problems, something that, you know, it's not acute. You have other counts in the 2 years before the diagnosis was done. All those things that make you think this is something constitutional, then we go to a really high, deep genetic screening. For adult patients, no. I would say no. For adult patients, if you don't have all what I told you, no family history, no other things that hematological disorders, and acute plastic anemia means normal CBCs in the last 2 years, and then something very acute, then we are not doing some genetic screening systematically. What we are doing, if the patient is refractory, then we are asking twice if we're not missing something. But just in this situation, we are not doing systematically in adult patients, except, of course, if they have something that makes us think we should do it. If you have a cancer and a plastic anemia at 30 years of age, of course, we're going to screen for Fanconi anemia, you see. But if we don't have any clues, and if PNH is positive, you see, then we have very strong arguments for idiopathic aplastic anemia. So basically, just to summarize my talk, because I want to be clear, if on the biological side we have PNH, for sure, we are already thinking of idiopathic. If we don't have alpha-fetoprotein increased, immune deficiency that is more associated with constitutional disorders, we are not doing screening. And on the clinical side, family history, something as a hematology, not an acute disorders, not normal CBCs in the last 2 years, then we are doing the genetic screening.
And just to follow up to that question, does that strategy change when you're looking at young children? Is there a preference for whole exome sequencing versus an NGS panel, or sort of a test is a test in your opinion?
Yes. So at the moment in kids, we decided to run a panel for everybody. So if you have a plastic anemia, I would say less than 10 for sure, and less than 18 we are coming to. What we are doing first is obviously a breakage test, because this is easy, but we are going quite quickly to the panel, and you will see all the genes that we are testing in the publication from Blood is 2018. The first author is Pewiąault, Bluteau, and the last author is Soulier, Jean Soulier. And that comes from the work we did in the French Reference Center on patients who were really at high risk of constitutional disorders, was 178, who were not presenting Fanconi anemia. It was tested, it was negative. And on those patients, we find for 50% of them another gene that was responsible for their plastic anemia. There was SAMD9, SAMD9L, ER6, L1. There was many older genes, Day2 and so on, telomeres. And so we have a panel with 40 genes that we are screening up front for those patients. And yes, at the moment, for the patients that we think they have strong arguments for a constitutional disorders, we have this whole exome sequencing that is ongoing in France since it's very recent. It's in 6 months.
Another question, do you have any subset data for either your mismatch unrelated donor transplant or ethnic minorities? In particular, I think as we've looked at upfront unrelated transplant, we've had some caution or concern in minority populations given the lower likelihood of finding a suitable donor. So do you have any sub-analysis either by ethnicity or by mismatch unrelated in particular, even pulling out of the mismatch ethnic minorities?
Yeah, so no, I don't have any data on this. Because of the risk of this approach of match unrelated donor upfront, we decided to target only patients who have a very good probability of match unrelated donor available, because we think it's so risky that you could not. To answer to your questions, and there was one of the limitations of this, of course, procedures, and that was in my slides, because again, we don't have all the donor. So to answer to your questions, we don't have any data on it, but there is more and more data coming from Baltimore, from the Brodsky group, showing that using Pewiąault first line, you may also have some good results. So this might be also something to explore. The risk, of course, is higher, but it's true that it looks that the data are good to use Pewiąault with post-transplant cyclophosphamide, the Baltimore protocol. So that is something that is going on. I would not say with mismatched donors, but what I can say is what has been presented and published by the Baltimore group. It was 1 year ago for the use of Pewiąault first line. There was some deaths, but very few. So I would say that if we are speaking about minorities, in France at least, they will go for immunosuppression because, again, we don't want to be at risk of this kind of procedure. But the data are generated at the moment in Baltimore, and it doesn't seem so bad, even good, but need to be, of course, confirmed on a higher number of patients in our prospective trials.
Well, thank you again for a wonderful talk and a very engaging question and answer period. With that, I'd actually like to go to our next speaker. So if we can transition the slides while we're doing that, a little bit of housekeeping. Once again, a reminder to use the Q&A box for any questions. Also, we've learned in day 2 of the symposium to add a little bit of break for attendees between sessions. So at the close of the transplant session, you will have a break. But of course, feel free to take breaks as you need it. And with that, I'd like to introduce our next speaker, Dr. Suneet Agarwal. Dr. Agarwal is an assistant professor of pediatrics at Harvard Medical School and co-program leader of the Stem Cell Transplant Center at Dana-Farber Boston Children's Hospital. His lab studies the continuum of bone marrow failures from efforts to identify causative biologic mechanisms using induced pluripotent stem cells to performing mitochondrial genome engineering and gene editing, with the hope of uncovering additional curative approaches. Today, Dr. Agarwal will share with us his experience with transplant for bone marrow failure associated with telomeropathies. Dr. Agarwal.
Great. Thanks so much, Tezo and Stacy, for this invitation to this great symposium. Also to Peter and the organizers for inviting me. It's a pleasure to be part of this distinguished group of speakers. I see already that there may be some formatting issues with my slides, so forgive us, and we'll try to plow through that as well. Next. So I have no relevant disclosures, and as usual, everything that we're using in bone marrow transplantation is off label. Next. So I'm going to try to describe to you now the experience that we've had in transplant for dyskeratosis congenita, which is now an 8-year prospective study, which I believe is finally ripe for describing the data. These things always have a long lead time. And Dr. Richa Sharma gave a very nice introduction to this yesterday, but I'll just recap so we're on the same page. So dyskeratosis congenita is a prototypic inherited marrow failure disorder that's characterized by a mucocutaneous triad of skin pigmentation abnormalities, oral leukoplakia, and nail dystrophy as shown here. And these are the outward manifestations of a systemic degenerative disorder with high rates of tissue failure, including bone marrow failure in the classic presentation shown by Dokel in the bottom right, greater than 90% by age 40, high rates of pulmonary and hepatic disease, and essentially any organ system can be affected, and this is a cancer predisposition syndrome as well. Next. Genetic discoveries have shown that dyskeratosis congenita is caused by mutations in genes that regulate telomere maintenance. So telomeres are the hexanucleotide repeats at the ends of linear chromosomes that exist in hundreds to thousands of copies. These undergo shortening with every cell replication, and when the telomere reaches the critically short length, the cell stops dividing. That's programmed senescence and as a normal physiological mechanism to protect genome integrity. So in cells that have self-renewal capacity and also in cells just to maintain telomere length through these cycles of replication, there's a complex structural machinery and also the ribonucleoprotein complex telomerase in stem cells to maintain replicative capacity. And as you can see here in bold and in color, any number of genes involved in this mechanism can be mutated in dyskeratosis congenita, and there's a lot of heterogeneity, which is a characteristic of this disorder based on genotype and also on age and other factors and inheritance pattern as well. Next. The genetic findings and also the implementation of clinically validated telomere length testing has shown over the past 15 years that dyskeratosis congenita is one of a spectrum of genetic disorders of telomere biology, ranging from even more severe infant onset forms of the disease to the de novo presentation in adults of germline disorders, as has been discussed in terms of aplastic anemia and myelodysplastic syndrome, but also liver disease and pulmonary fibrosis extending into the 5th, 6th, and 7th decades of life. So again, emphasizing the heterogeneity of this disorder. Next. So an understanding that dyskeratosis congenita is caused by problems with telomere maintenance provides a framework for understanding at least the bone marrow failure manifestations in this disease. The blood stem cell is responsible for the output of hundreds of billions of cells per day, and its self-renewal is required to maintain this massive output. Telomeres undergo attrition over the course of life in the hematopoietic compartment, and telomerase is insufficient as shown by the age-associated decrease in telomere length on the prior slide. And so it's understandable that if there's a problem with the telomere length to start with, or in a maintenance mechanism, there's a premature exhaustion of stem cell self-renewal and output that can account for marrow failure and the other sequelae, such as clonal evolution, MDS, AML perhaps. And it's also known prior to knowing about what the biological mechanisms were that allogeneic bone marrow transplantation was curative, and that indicated that this is at least in large part a HSC cell intrinsic problem. But at the same time as knowing that bone marrow transplantation was curative, it has also been known for a long time that there are a lot of complications from bone marrow transplantation. Next. So several retrospective studies, and I'm showing one on the left, several listed across the top, showed that if you look at the literature, there's a high rate of early mortality in bone marrow transplantation for patients with dyskeratosis congenita, 25% within a few months of transplant, and a very unsatisfying rate of death in the years that follow. And in another study that I'm just highlighting here, it's also retrospective, but of large groups such as EBMT, EWOG, MDS, and University of Minnesota, it's seen the same thing, which is a high rate of early mortality within months and then an ongoing low survival over the course of years with high rates of complications, including graft failure. And so at least a large part of this can be accounted for by treatment-related mortality and likely conditioning toxicity given the acuity of the death. And that likely accounts for poor short-term survival. But then further beyond that, the overlap of DC pathology in the liver and the lungs and the target tissues the tissues that are targeted by conditioning toxicity and GVHD lead possibly to the acceleration of onset of other non-hematopoietic disease and morbidity and mortality. It's also known that patients present sometimes simultaneously with both a hematopoietic and a non-hematopoietic problem, and those types of comorbidities limit BMT eligibility. So these outcomes and those types of comorbidities make bone marrow transplant a limited modality for therapy for these patients historically. Next. So this is a slide that's unnecessary, but it's BMT-101, and I really show it to emphasize the role of alkylating agents and radiation still to this day in bone marrow transplantation. So it's been known for decades, of course, that these agents are the mainstays of bone marrow transplant because of their very strong anti-tumor effect when doing transplant for leukemia, their strong immunosuppressive effect to enable engraftment, and their ability to create niches or space, physical space, to allow engraftment. And so these are highly effective, and it's important to point out that one or both of these agents is still used in every allo transplant regimen that aims to achieve myeloid engraftment to this day. These agents are also responsible for, as non-targeted genotoxic agents, for collateral tissue damage, the short and long-term toxicity of transplant in some part, and also for provoking GVHD. And these are considered, to some degree, necessary evils. Now, of course, some patients, especially in our category, can't tolerate these problems, and also the elderly. And so moves have been made over the past decades to limit the doses of these agents and to introduce antibodies and fludarabine. But still, these agents are used to some degree in all of those regimens as well. So in 2012, we asked the question, given the outcomes in the patients with DC and the emerging biological understanding, can radiation and DNA alkylating agents be eliminated? Next. And since what we're really looking for is to avoid the toxicities, and there's no, in a marrow failure situation, there's no need for an anti-tumor effect. And this is a typical appearance in our experience of the way a marrow looks for a patient with DC, so no real need to create space. Next, so could we get away with an immune suppression only approach in a DC patient with marrow failure and achieve durable engraftment and improve outcomes? Next. So the rationale here that comes from the biology is that the telomere defect in DC patients should result in a replicative disadvantage in hematopoietic and immune cells, which should favor engraftment. And we're trying to take advantage of that in a severely reduced intensity conditioning regimen. And then, of course, as said before, eliminating these agents will reduce the risks of organ failure and secondary malignancy to which DC patients are predisposed. And finally, the other concept behind this trial was that given the heterogeneity of the patients and also the unpredictability of BMT, no matter how many factors are controlled, there is a great degree of heterogeneity, and it's going to be hard to predict the outcomes. So if one were to say we could start in marrow failure with a low intensity regimen and see how many people fail and whether or not they could be salvaged because they've been exposed to less, will that make it feasible? And of course, all of that depends on what the rate of primary engraftment is and then of salvage as well. So just going back to the first point, what is the evidence for the telomere defect in C cells resulting in a replicative disadvantage? And this is not modeled easily in any type of preclinical animal model, but the evidence comes from human genetic studies and also experiments, which are essentially transplant. Next. So the first piece of evidence is coming before even knowing the actual mutation in dyskeratosis congenita, that of the patients, the males who had X-linked dyskeratosis congenita, the female carriers in those pedigrees showed skewed X inactivation, non-random X inactivation distribution in the blood cells. And that subsequently has been shown to be a skewing away from the allele that carries the mutant DKC1 gene. So in a one-to-one setting, the cells with the impaired telomere maintenance mechanism are selected against. That's one piece of evidence. The second piece of evidence came very early after the acknowledgement of or the discovery of the mutations. Next. And that is an experiment that basically shows that the cells that carry telomere gene mutations actually have difficulty with engraftment. They actually don't engraft very well. So in this case, an adult patient in whom a TERT mutation was unknown, presenting with aplastic anemia, is transplanted by the sibling A9. So A14 was transplanted by A9, if you can make out the slide there, and that patient was not known to carry a mutation, and that patient had graft failure and then succumbed to the disease, and subsequently it was found that the family was carrying TERT mutations, and some of the adult patients were not symptomatic or showing signs yet. But finally, probably the best evidence that there's a replicative advantage of cells with intact telomere maintenance mechanisms next comes from an example in this disease, as was discussed yesterday for SAMD9, SAMD9L, and also for the RPA1 mutation that Richa Sharma showed, is evidence of somatic reversion of TERT mutations. So in heterozygous TERT mutations in a pedigree, some family members who were obligate carriers were not found to have in their blood the TERT mutation, and on closer analysis, what was found is that those patients had undergone somatic recombination, and those individual clones that could be actually ascertained by SNP arrays had actually taken over the entire hematopoietic system, both in the myeloid and lymphoid lineages. So that's a pretty powerful example of a cell being, with an intact telomere maintenance mechanism, being able to take over too. So I just wanted to highlight this literature as some of the rationale. Ultimately, once again, though, for the protocol that we had, we didn't really have any preclinical data, just this type of evidence to base it on. Next. So this brings us to the trial. So the trial that we ended up undertaking in 2012 was of alemtuzumab, Campath, anti-CD52 monoclonal antibody, and fludarabine alone. So the alemtuzumab, just to describe it in a bit of detail, the cumulative dose of alemtuzumab is typical, and the positioning of it is proximal to intermediate compared to the time of engraftment, which is important for depletion of the lymphocytes from the graft in vivo, and we'll talk about that more. The fludarabine dose is 180 milligrams per meter squared cumulative, which is pretty typical. For this regimen, we insisted on a bone marrow graft to avoid GVHD, and then also in the GVHD prophylaxis regimen, we avoided methotrexate and steroids, regardless of related or unrelated donor source, to avoid tissue damage and also osteonecrosis, osteopenia to which the DC patients are predisposed. Next. So the eligibility for this trial was pediatric and ultimately adult age range. This is a protocol for myeloid failure. Again, these patients get MDS, AML, immune dysregulation, immunodeficiency, but this is for patients who have myeloid failure based on what we're trying to achieve. So the bone marrow had to be hypocellular for age, and the patient should have one or more significant cytopenia or transfusion dependence. And importantly, telomere disease, especially in 2012, was defined not entirely precisely, and we decided to actually have a large catchment of patients as opposed to trying to define it extremely strictly. So the eligibility criteria could be the clinical syndrome or a known pathogenic gene mutation in the setting of knowing that we don't know all the genes for DC even to this day, or lymphocyte telomere length by flowfish that was less than the first percentile. That was shown by Alter and colleagues to be highly sensitive and specific for dyskeratosis congenita in a pediatric myeloid failure cohort. The patients should have an HLA 7 out of 8 or better match, related or unrelated donors. And the only organ function requirement was adequate renal function for the fludarabine. In terms of exclusion criteria, what was highlighted once again next is the exclusion of patients with MDS, and here defined, especially in a pediatric age range, of those with cytogenetic abnormalities such as del7q or monosomy 7 clearly associated with MDS, not based on IPSSR score, for instance, which becomes relevant, excluding AML, and also a performance score less than 40 was tolerated, and the patient shouldn't have an anti-donor HLA antibody in the case of mismatched BMT. Importantly, there were no exclusion for liver or lung disease because the idea was to try to increase eligibility when using a minimal intensity regimen for those patients who are indeed stuck between having organ dysfunction and marrow failure concurrently. Next. So the objectives were, as a primary endpoint, to show engraftment as defined by an absolute neutrophil count recovered to greater than 500 per microliter for 3 days by day 42, and that it should be primarily donor cells by day 100. And we aim to track several secondary endpoints, short-term survival, durability of myeloid engraftment, GVHD infections, immune reconstitution, and then ultimately to try to have a long-term follow-up both for survival, also late effects, and then to try to track what actually happens to those other non-hematopoietic comorbidities, whether successful or failing through this transplant regimen. Next. So this trial opened up as a single center, single arm prospective trial at our center in July 2012. And then with some, once we had a little bit of experience with this and success with it, we formed a consortium and also expanded next the protocol to several centers, and that expansion continues. But we set as an accrual goal any of 20 patients, and we achieved that in October 2018. So the reason I say that we are finally ready to present this, even though some of you may have heard parts of it before, is that we have 2-year follow-up on the most recently treated patients. And this then shows at the time the centers participating and the number treated, with us treating most of them just because it was a single center for some part of the experience in the early days. And the Dana-Farber is listed there separately as the adult side for this protocol as well. Next. So these are the clinical features of the study subjects. So we had 20 patients, 11 male and 9 female. They were across a broad age range of 20 months old to 31 years old, with more than 5 patients above 20 years old at the time of transplant. As would be expected, we had a lot of genetic and phenotypic diversity with early onset and multi-system disease versus non-syndromic. We were able to define several of the mutations in the patients, and some remained unidentified, as would be expected. 2 of the transplants were matched SIB, and very importantly, 18 were unrelated donor transplants, which have historically had worse outcomes, but this is what was available, and this was part of the eligibility. Most of them were 10 out of 10 matched, and 3 of them were 9 out of 10, even though 7 out of 8 would have been acceptable. This was the matching that was being done in this era. Importantly, 4 of the patients had transplant-limiting comorbidities and would not have received transplant at our center, frankly. So 2 with significant liver disease and 2 of them with low DLCOs, and this is due to pulmonary right to left shunting, which is hepatopulmonary syndrome, most likely in the pediatric age range. Next. So these are the results. So this is primary engraftment, which is a primary endpoint, and so this is recovery of absolute neutrophil count to greater than 500. So 19 of the 28 patients engrafted by day 42. The median was 22 days, and the range was day 1, and then subsequently to day 35 for those who were successful, and ultimately day 47. And I'll just go on a tangent for a moment and tell you about the day 1 and the last patient who didn't technically engraft next. So for the patient who didn't engraft, this was subject 7. This patient came in with liver disease, portal hypertension, and bleeding varices, but was eligible still for this protocol. She showed a primary graft failure with a very low ANC and low platelet count that was refractory to transfusion for 42 days. And so as we were planning her second salvage transplant, we were trying to understand what the causes might be contributing to this. And we recognized that she had a very large spleen and decided to take out her spleen prior to the second transplant next. And what we found was that upon splenectomy at day 47, she promptly recovered her ANC and became much less refractory to platelet transfusion. So essentially, she was not showing her graft. In the background, her donor chimerism was increasing with these very small numbers, but she was not showing her graft because of hypersplenism. And ultimately, she required a CD34 selected unconditioned top-off, but did not, months later, but did not require a second allo transplant. Next. With regard to the patient who engrafted on day 1, so this was the patient's ANC after transplant. So the patient didn't have an ANC less than 500 during the entire protocol. It came in mainly with thrombocytopenia rather than very severe neutropenia. And what we found here in the background next was that over the course of 60 days, the patient's myeloid chimerism shifted entirely from recipient to donor over that period of time as well, which shows some of the limitations in the endpoints of the protocol here. Next, so just getting back to what happened with the patients, the main thing that we want to know is whether or not these patients had durable myeloid engraftment over the course of time. So this is a graph showing all 20 patients. So all of them, in terms of protocol criteria, met donor chimerism criteria by day 100. And 17 out of the 20 had sustained myeloid engraftment defined both by myeloid chimerism and also maintenance of the ANC. And the chimerism follow-up is up from 3 to 84 months. Next, so 2 of the patients had what we feared, which was an early rapid graft rejection. This was most likely immune-mediated, although they were 10 out of 10 matches and we didn't see any antibodies. These patients underwent salvage BMT with a higher intensity regimen and new donors. One of them was very straightforward and the other one was very complicated, but both were successful and both are alive. In terms of the other graft failure, the other one was a secondary graft failure with an ANC less than 500 that was persisted despite high donor chimerism in the setting of viral infections. And this patient, as I'll show you, succumbed to a fungal infection. Next. We were able to track in a research-only opt-in marrow evaluation because we do not track marrow evaluations in patients post-transplant for aplastic anemia. As a matter of routine, some of our other participating centers did and were able to contribute the data. So at the time of clinically indicated procedures under anesthesia, some patients contributed to this aspect. So we were able to track cellularity, and one thing that we can see here is that the CD34 chimerism at the time of those evaluations as early as 60 days seems to be quite high. And in the 2 cases of graft rejection, those CD34 chimerism values were lower. So this is interesting and possibly predictive. Next. In terms of acute GVHD, none of the patients had acute GVHD. None of the 20, and 3 of them are censored, of course, here, 2 of them for graft rejection and 1 of them for death. But this we attribute to the fact that we use Campath and also that we didn't cause any tissue damage during the process of the transplant. Next, in terms of chronic GVHD, 4 patients of the 17 evaluable developed either limited skin or GI or 1 extensive because of mouth and GI involvement, de novo chronic GVHD, and all of these resolved with either short courses of oral steroids or topical steroids over time. So there's no patients with chronic GVHD presently. Next. In terms of immune reconstitution and infections, of course, with Campath, some viral reactivations are expected, and these were tracked in all patients. In patients with setups, 7 of 20 developed CMV viremia and 5 of 20 EBV viremia. There was 1 patient with a Klebsiella sepsis that was treated, and 1 patient with disseminated mucor. That was the patient I was describing with the secondary graft failure, and that was fatal. And in terms of immune reconstitution, the IgG level was normal throughout, so I don't think we deplete plasma cells in this regimen. And of the 17 evaluable patients, what we find in these patients is that they get normal B and NK counts, but interestingly, and actually, regardless of regimen, what we find is that some patients with DC have persistent T lymphopenia for some period of time. Next, the chimerism in the CD3 lineage, which is also, which is highly variable, it can be very, very low in the beginning and actually gradually increases so that all the patients here, 19 out of the 20, had high mixed chimerism or full chimerism, except for 1 patient that's lower there. Nevertheless, these patients, we haven't adjusted any of their immunosuppression or done DLI. They have intact immune responses to vaccines and no opportunistic infections or prophylaxis. So this regimen does result sometimes in a split type of chimerism between the myeloid and lymphoid lineages, which I believe has also been seen in the FCC regimens for severe aplastic anemia. Next. This is overall survival. So 17 of the 20 patients are alive with median follow-up of 40 months, a range of 24 to 98 months. There's 1 PRM from the fungal infection at 3 months post-BMT, and 2 disease-related deaths, 1 from GI bleeding and 1 from complications of liver transplant, as shown here. Next. So the conclusions are that alemtuzumab and fludarabine is an effective conditioning strategy in BMT for bone marrow failure in patients with DC or very short lymphocyte telomere length where we're not able to define the mutation or the syndrome, and they were still eligible here. We see favorable engraftment, salvage, GVHD, and overall survival rates, and this protocol may enable transplant in patients with high-risk comorbidities. The broader implications next of this regimen are that this is the first series of patients in allo-BMT to achieve durable myeloid engraftment without any exposure to alkylating agents or radiation, showing that these are not required for myeloid engraftment in specific clinical settings. And I think that the marrow failure setting would be the best place to investigate this. This has a significant impact on how we think about the sequelae of BMT and late effects in this patient population because they are not exposed to those agents that cause late effects once they achieve myeloid engraftment by this regimen, and hopefully we can see what then the natural history of the disease is. Next, so the current plans are we have expanded this study past the first accrual goal. Currently we have 15 centers, here shown Hackensack, Duke, Oslo, Children's Hospital, Mercy in Kansas City, and Mayo Clinic, and then at the end is 27. And the plan is to try to initiate or consider formal studies in other BMF disorders. And again, long-term follow-up of our cohort is essential as well. Next. So finally, and again, the most important slide, the acknowledgements. So of course, any type of clinical trial takes a huge number of people to execute, and I'm just reporting on their behalf. So the first to go across the top is to talk about the patients and families and the patient advocacy group that started off as Dyskeratosis Congenita Outreach, organized by Sharon Savage and Blanche Alter almost 12 years ago, has basically turned into quite a force called Team Telomere, both to support the community and also disseminate ideas, participate in trials, and actually raise funding. So here we see Team Josh and the DCO riders who, with the Penn Orphan Disease Center and the $1 Million Bike Ride, raised a grant with Team Telomere that funded the provided funding for the multi-center expansion of our study. And you'll see Tim Olson kind of hiding in the corner there as well. I'd like to thank the folks at our institution, Dave Williams and Leslie Beeman, for their vision and mentorship, and the rest of our team, Wendy London, Allison McCrary, Maggie Mulch, Kelly Verrill, and Andy DeMarsh, and our entire transplant team. And also, this was supported at our institution largely by philanthropy, as shown there. And then finally, it's been a career highlight for me to, via this protocol, get to know such an amazing group of dedicated colleagues across the country and the world who've shown incredible dedication to this protocol, and I've learned a ton from them, and they're listed here as well. So thank you very much, and I'd be happy to take questions as time permits.
Thank you, Dr. Agarwal. We do have time for a couple of questions. First, there is a question about the patients who had early graft rejection, and specifically wanting to know what higher intensity regimen was used.
Sure. So the two patients who had graft rejection were definitely DC patients with empty marrows, with a 10 out of 10 unrelated donors without antibodies that we could see of any kind. So they were a mystery that they rejected the way they did, and we couldn't solve it. Fortunately, they each had another 10 out of 10 unrelated donor. And in one case, we used for a 2-year-old or 3-year-old a Pempath-Flu-Mel regimen, 70 of Mel, which was pioneered at Cincinnati. And then the other case, we used a Minnesota regimen, which was Pempath-Flu, 200 of TBI, and 50 of cyclophosphamide.
Great. Another question, can you expand upon chimerism beyond CD34, whether that's whole blood, myeloid, or any other subsets? And then a second part of that question is, do you think the lower T-cell immune reconstitution is related to the primary disease process versus the conditioning risk?
So great questions. So I showed the peripheral blood chimerism. It's being tracked in myeloid, and so CD33, CD66, CD15, depending on the center, and CD3. And then there was just that graph of the more unusual thing to track there when available, which was a CD34 chimerism in the marrow. So that was in some of the data that was presented. And sorry, the second part of the question? Oh, yes, I see it. The T-cell immune reconstitution. So it appears that there's persistent T lymphopenia as a specific subset defect in these patients post-transplant, which is probably some sort of thymic or extrathymic maturation problem in DC patients. And that's seen not only in our regimen, but in other people who have not received Campath. The Campath is certainly causing a slow appearance of peripheral T lymphocytes. And I think that ends up revealing the fact that there's very little donor-derived CD3 component, and that's why we have a delayed chimerism of that compartment as well.
And one last question before I then have to refer you to the Q&A, and we'll have to move on. But from Peter Curry, wonderful presentation and great data. Did younger patients do any better? And is there any difference in outcome or complications by age or genotype?
Yeah, I think the number is too small to be definitive, but if you want my impression, it's the two deaths were in the older patients, oldest patients in the cohort who had liver disease concurrently. The shorter term deaths, the younger patients do quite well, actually, even if they have some comorbidities, because they're not usually overt organ related. So the 4-year-olds are fine. They are progressing to actually then in the years that follow, however, have those other sequelae.
Well, thank you very much for a great talk. There are 3 remaining questions in the Q&A, which we would appreciate if you could address there. And with that, we will transition to my colleague and co-chair, Dr. Nakano, who will tee up the introductions for the remainder of our session. Kaizo?
I was muted, sorry. Thanks so much for the transition. I'm actually going to introduce the next two speakers up front here so that they can share the next time slot. The first of the two is Dr. Cass Myers. Dr. Myers is an associate professor at Cincinnati Children's Hospital in the Division of Bone Marrow Transplant and Immunodeficiency. She's well known to the NAPAC community for efforts to co-direct the North American Schwachman Diamond Registry. We appreciate all of the kind of collaborative efforts she's organized for Schwachman Diamond, most recently in the retrospective review of patients that develop MDS and AML, and currently the efforts she's undergoing to organize us all to study liver disease and telomeropathies. You would think with so much experience organizing NAPAC collaborators together that it just seems odd to me that she's not a NAPAC member. I'll just put that out there on the table and let that simmer. The second presenter after Dr. Myers, we're joined by Dr. Lori Burrows of Seattle Children's Hospital. So Dr. Burrows is the director of the non-malignant transplant program at the Hutch. We all know Dr. Burrows, well known for her clinical research, but I would also point out that she was one that has organized one of the first successful multidisciplinary discussion platforms, web-based or phone-based discussion platforms, the non-malignant review board that probably many of us have participated in. Dr. Burrows was doing it before it was even cool, before the world shut down. So, has a lot of experience with that. Her clinical focus has been to develop gentler conditioning regimens for transplant. And so we'll start with Dr. Myers and then follow with Dr. Burrows. Cass?
Thanks, Tezo. And I'd like to let you know that it's in the hands of the lawyers at the moment. We are hoping to join NAPAC soon. So thanks for that kind introduction, and thank you for inviting me here to speak today about transplant for Schwachman Diamond syndrome. Next. I'm just going to briefly outline what I'll cover in the talk today. First, we'll talk about some implications of the diagnosis of Schwachman Diamond syndrome when considering a stem cell transplant. We'll discuss both historic and new approaches to transplant for SDS, and then I'll touch on some future directions of where we may need to take therapy for patients with Schwachman Diamond syndrome in the future. Next. We all know that Schwachman Diamond syndrome is an inherited bone marrow failure syndrome with predisposition to myeloid malignancy. Classically, patients have cytopenias in conjunction with exocrine pancreatic dysfunction, and the most common cytopenia, of course, is neutropenia, which can be quite intermittent in some patients. The vast majority of patients have biallelic mutations in the SBDS gene, and that's about 80 to 90% of all patients. And the diagnosis of Schwachman Diamond syndrome is associated with poor growth and failure to thrive, congenital anomalies in about 50%, most often skeletal, although they can be quite varied. Neurodevelopmental manifestations are also common, as is transaminitis of sort of cryptic etiology that's most commonly seen in infancy and does resolve with time. As I mentioned, SDS patients are at high risk of malignant transformation to MDS or acute leukemia, and that risk is about 10 to 35% over the first several decades of life. Schwachman Diamond syndrome is a ribosomopathy, and the SBDS protein promotes the joining of the 40S and 60S ribosome subunits. In the last several years, several patients have been described with SDS-like disease with mutations in SRP54, DNAJC21, and EFL1. Next slide. So I told you what the textbook says about Schwachman Diamond syndrome, but the diagnosis is not always that straightforward and often can be quite cryptic. Now, in a paper a few years back through the Schwachman Diamond Syndrome Registry, we were able to demonstrate that the clinical phenotype of patients with SDS is significantly broader than previously assumed. Approximately 50% of patients present without the classic combination of neutropenia with failure to thrive or steatorrhea, making the index of suspicion needing to be high when evaluating patients for marrow failure for the diagnosis of Schwachman. We were also able to identify asymptomatic siblings who were diagnosed based on familial genetic testing because the clinical phenotype was subclinical. And this highlights not only the importance of the care of those siblings as far as malignancy screening, et cetera, but also in the setting of considering a stem cell transplant when looking at related donors. Next slide. Considering the adult and the MDS population, Shwachman-Diamond syndrome can be hiding there as well. And some lovely work from Coleman Lindsley in Boston in collaboration with the Center for International Bone Marrow Transplant Research. They were able to do targeted mutational analysis on pre-transplant samples from over 1,500 patients transplanted for myelodysplasia. And what Coleman was able to see is that 4% of young adults, those under 40, harbored compound heterozygous SBDS mutations with concurrent TP53 mutations. And unfortunately, these patients had a very poor prognosis. Next slide. So why does it matter? Bone marrow failure is bone marrow failure, right? Hopefully I'll be convincing you otherwise. Next. So when do we consider transplant in Shwachman-Diamond syndrome? Similar to many other marrow failure syndromes, when there's severe aplastic anemia with transfusion dependence, for profound persistent anemia with recurrent infections, and also for high-risk cytogenetic abnormalities such as monosomy 7. I want to take a moment here to highlight del20q or isochromosome 7, which are very commonly seen in patients with Shwachman-Diamond syndrome and have been shown not to be high risk for a malignant transformation alone without the presence of additional cytogenetic abnormalities or morphologic dysplasia. And certainly, bone marrow transplant can be considered for patients with myelodysplastic syndrome or acute myeloid leukemia in the setting of Shwachman-Diamond syndrome. Next. So looking back at historical full intensity myeloablative regimens, these regimens had extremely poor outcomes for patients with SDS with high rates of transplant-related toxicity, with Cesaro et al. And the EBMT reporting a TRM of 35%. With higher TRM in TBI-containing regimens of almost 70% compared to non-TBI regimens. Overall, the literature is filled with case series and case reports demonstrating a high incidence of graft failure and graft rejection, as well as increased risk of cardiac, liver, and pulmonary toxicity and infection as well. Next slide. So we looked at the registry experience for transplant with Shwachman-Diamond syndrome, and we found 25 subjects had 27 transplants in the SDS registry, and this is 16% of our 159 subjects who have biallelic mutations in SBDS. No patients with genetically undefined Shwachman-Diamond syndrome or mutations in SRP54, DNA-JC21, or EFL1 had a need for a stem cell transplant in the registry. Indications for transplant included severe aplastic anemia in 8, del20q in 2, again before this was known to not be an indication for transplant, MDS in 10, and AML in 5. Next. And you can see here that patients with MDS and AML are much older than those with aplastic anemia. Next. In fact, 6 out of 8 patients with aplastic anemia were transplanted prior to the age of 2.5. Next slide. A little over half of patients had a reduced intensity preparative regimen for their transplant, and a little over half had an unrelated donor. Next slide. And 2 patients required a second transplant, both for relapsed disease. The overall survival of this cohort is 52%, and you can see that there is very poor survival for subjects with AML. Not surprisingly, treatment-related mortality, both for organ toxicity and infection, as well as relapse disease, were causes of death in this cohort. Next slide. So moving past the registry experience, this year 2 papers were published, one from the CIBMTR, the US-based registry, and one from the EBMT out of Europe, with 52 and 72 subjects respectively, looking at transplant outcomes in patients with SDS. And they were able to show that outcomes for bone marrow failure are improved at 72%, while outcomes for AML and MDS remain quite dismal at 15%. Of note, neither paper had the power to demonstrate superiority of reduced intensity or reduction of intensity over myeloablation, although it is our clinical gestalt that reducing the intensity has improved outcomes over time, which I'll show. Next slide. As Pejąlt mentioned, the registry recently led an effort, a collaboration of 18 centers looking at the diagnosis of MDS and AML in patients with Shwachman-Diamond syndrome. And this is 36 patients here. And this study was able to detect a difference in outcomes between patients with MDS and AML. And this is important here because historically, MDS and AML have been analyzed together. So looking at outcomes, the 3-year overall survival for patients with MDS was 51%, with a median survival of 7.7 years, compared to a 3-year overall survival of 11% for AML, with a median survival of just under a year. So obviously, we need to make some improvements to change these outcomes. Importantly, the study was able to demonstrate that a survival advantage for patients undergoing active marrow surveillance compared to those not undergoing surveillance. Next slide. So this highlights the importance of identifying novel methods and markers for early identification of high-risk patients or impending leukemia in Shwachman-Diamond syndrome. Several years ago, Dan Link, in collaboration with the registry and many others, was able to demonstrate clonal hematopoiesis due to mutations in TP53 in a cohort of patients with Shwachman-Diamond syndrome. But this was really a snapshot in time, and the clinical implications of having those mutations were not clear. In a paper under revision that's available in bioarchives, Alyssa Kennedy in the lab of Akiko Shimomura and Coleman Lindsley was able to take a look at longitudinally at a cohort of 110 patients with SDS from the registry who have clinical annotation. Alyssa was able to identify multiple distinct somatic clones that developed at a very early age in these subjects. And the most common mutations were heterozygous mutations in EIF6 or in TP53, and these were distinct clones. EIF6 mutations, Alyssa noted, alleviated the ribosome joining defect, improved translation, and reduced P53 activation, and this is sort of a functional compensation for this SPDS deficiency. TP53 mutations did decrease checkpoint activation, but did not affect ribosome assembly. So really the context of these mutations within a given cell may inform risk, as patients with biallelic TP53 mutations went on to develop leukemia. These data support the integration of single-cell DNA sequencing to serial marrow surveillance. And in fact, this is currently being offered on a research basis by the registry with a return of clinical results, although the timing of return of results may not be in a clinically actionable timeline. Next slide. Another area in which we need have room for improvement is our approach to AML in Shwachman-Diamond syndrome. Traditional high-intensity chemotherapy approaches have really just met with high toxicity and, despite that, resistant disease. So we really need to think of a way to change our approach. One of these ways is improved transplant strategies, which I'll discuss, but also we need novel AML-directed approaches to address the disease prior to sending the patient to transplant. The field of leukemia therapy has really evolved over time and become more targeted, with less cytotoxic approaches being more common. So targetable therapies could be considered if targets are identified by sequencing panels, for example, a JAK2 mutation and the use of ruxolitinib. Also, one could consider hypomethylating agents either alone, in conjunction with targetable therapies, or with something like venetoclax. And this is a promising approach that could potentially be less toxic. Courtney DiNardo and colleagues very recently reported their use of decitabine with venetoclax in older adults with AML upfront for those ineligible for intensive chemotherapy or for relapsed refractory disease. The overall response in this study was 74%, with a very promising 89% overall response in newly diagnosed AML. And importantly, this therapy appeared to be very well tolerated in this fragile population. In fact, we have an institutional experience of this approach in a patient with Fanconi anemia and AML, who is now MRD negative 5 months post-transplant. And certainly other novel approaches such as cellular therapies are being developed and tested. Next slide. So looking closer at changes in transplant therapy, as we've mentioned, patients with SDS do have increased sensitivity to very high intensive regimens, including those containing cytoxan or radiation. And so the goal of these changes was really directed at limiting toxicity. Next slide. So I'm going to discuss two different approaches, one a reduced intensity approach using campath, fludarabine, and melphalan, and the other a reduced toxicity approach maintaining myeloablative therapy but using treosulfan, fludarabine, and ATG. Next slide. So this is an update of the Cincinnati reduced intensity experience previously published. It's a campath, fludarabine, and melphalan regimen, as shown here, and we've transplanted 14 patients with SDS, all with SPDS mutations, using a predominantly unrelated bone marrow stem cell source at a median age of 6.2 years, and the majority of patients were transplanted for bone marrow failure, 3 patients for MDS and 2 for leukemia. One of the leukemia patients was pretreated with Ara-C, and the other went to transplant without cytoreduction. Next slide. All patients rapidly engrafted, and all remained fully engrafted except for the 1 patient who relapsed. Acute GVHD was low in number and mild, except for 1 patient who had grade 3 to 4 GVHD. 1 patient developed chronic GVHD that has subsequently resolved. And importantly, there was no significant cardiac or pulmonary toxicity. Next slide. 10 patients are currently surviving at 8 months to greater than 15 years post-transplant, and there is excellent survival for bone marrow failure at almost 90%. In the 2 patients with overt AML, 1 did relapse a year post-transplant and die of leukemia, and 1 died in remission of graft versus host disease 7 months after transplant. The 2 other patients died of infection, 1 an infant at the time of transplant with very profound neutropenia that had started at birth, and another young adult with advanced MDS. Next slide. I'll shift gears a bit and talk about the reduced toxicity approach, and I'm not going to go into a lot of detail here because Lori's going to speak about this at length, but this is a multi-center trial with a treosulfan, fludarabine, ATG approach, for which 4 patients have received transplant with Shwachman-Diamond syndrome, all with unrelated donor sources and all with SPDS mutations. The median age was 7.2 years, and again, all were transplanted for marrow failure, and all of these patients are alive and well without complications at this time. Next slide. So in summary, I really hoped to show you guys that we have some room for improvement here. We need improved markers for early identification of high-risk patients and impending leukemia, as well as novel approaches for the treatment of MDS and AML. I think reduction in toxicity has really helped in the marrow failure arena, but we need to improve care for those with malignant transformation. And really the way to do that is through clinical trials in which SDS patients are eligible for enrollment. So excited to hear Lori's work for the new trial through the BMT-CTN for marrow failure. And there's another trial under development for those with MDS and AML with underlying marrow failure, again using a treosulfan-based approach. And so keep your eyes peeled for that. Next slide. And here I'd like to thank all of our collaborators and referring physicians, the registry teams both in Cincinnati and Boston. A special shout out to Akiko, who's always been amazing and a fabulous mentor to me, our patients and families, as well as our support. Thank you for your time, and I'd be happy to answer questions.
So I think we're going to go straight into Dr. Burrows' talk. If you have questions and want to put them in the Q&A box, we'll go ahead and address them after Lori finishes her component. Dr. Burrows.